Hi, everyone. Welcome to our session, How Doctors Decide How to Treat Your Cancer. My name is Miranda Florick, and I'm an oncology nurse coordinator at Roswell Park Comprehensive Cancer Center. At most cancer centers, a multidisciplinary clinical team meets regularly to discuss challenging or unusual cancer cases at a meeting, sometimes called a tumor board. The goal of the meetings is to bring all of the experts into one room together to make recommendations on how best to treat a patient. A meeting that reviews kidney cancer cases may consist of doctors like medical oncologists, urologic oncologists, radiation oncologists, interventional radiologists, pathologists, and other clinicians like genetic experts, nurses, pharmacists, and clinical trial coordinators. We thought today would be a great opportunity to simulate discussions where our panel will review 3 cases and provide insight as to why they would recommend a specific treatment option for that scenario. Hopefully this gives you a behind-the-scenes look into how doctors collaborate with one another to treat patients with kidney cancer. I'm joined by several kidney cancer experts. Let's go around and have each panelist briefly introduce themselves. We will start off with Dr. Shapiro.
Hi, I'm Dan Shapiro. I'm a urologic oncologist at the University of Wisconsin-Madison.
And I have Dr. Plemick.
Hi, I'm Dr. Elizabeth Plemack. I'm a GU medical oncologist at Fox Chase Cancer Center in Philadelphia.
I have Dr. Hanan.
Hi, I'm Rakib Hanan. I'm a radiation oncologist at UT Southwestern in Dallas, Texas.
Dr. Sheth.
Hi, I'm Rollo Sheth. I'm an interventional radiologist at MD Anderson Cancer Center in Houston, Texas.
Dr. Kapoor.
Hi, I'm Payal Kapoor. I'm the lead genitourinary pathologist at UT Southwestern Medical Center, also in Dallas, Texas.
And Dr. Wang.
Hi, everybody. I'm Emily Wang. I'm one of the clinical pharmacy specialists with the GUMO service at MD Anderson Center, also in Houston.
And we can get started with our first case. Our first case looks at James, a 63-year-old man. He had his annual checkup with his primary care physician. His blood pressure has always been slightly elevated, even with medications. To make sure his kidneys haven't suffered any damage because of his hypertension over the years, his primary care provider recommended an ultrasound of his kidneys. Surprisingly, the ultrasound showed a 2.5 centimeter suspicious mass on his left kidney. A follow-up CAT scan of his abdomen and pelvis confirmed there was a mass on his left kidney and was most likely cancerous. Dr. Shapiro, how can a doctor determine if a kidney mass is cancerous just by reviewing a CT image?
Yeah, that's a great question that a lot of patients bring up when I see them in clinic. So we never know 100% for sure, just based on the imaging alone, if a tumor is cancerous or not. But things that we look for that make it more suspicious of being cancer is when someone gets a CT scan, we typically give them contrast. And that contrast agent can be picked up by the tumor, and it creates an enhancement of the tumor. And so we look at how the tumor picks up the contrast, and we know that cancerous tumors often pick up contrast quite quickly. And so if we see that enhancement, it makes us more suspicious that you might have a cancerous tumor. And that's why we always recommend whenever we see renal masses like on ultrasound, that patients either get a CT or an MRI to evaluate if they are taking up contrast.
Thank you. And Dr. Shapiro, would there be a reason to biopsy the mass at this time?
Yeah, so there's a lot of nuance that goes into deciding whether or not to get a renal mass biopsy. Typically, we do renal mass biopsies when we think that the biopsy might change our management. So oftentimes, if we see a younger patient that has a renal mass, we know that we'll probably want to take the renal mass out rather than committing the patient to getting surveillance scans for the rest of their life. Likewise, if someone's very old and it's just a small renal mass where we know that even if it was cancerous, it's unlikely to affect the patient, then we may not get a renal mass biopsy either. But in a patient like this one, if we find that the mass is actually benign, we may be able to avoid any intervention. So the biopsy can help us determine whether or not the tumor is actually cancerous. If it's a non-cancerous tumor, then surveillance may be a better option, versus if it's a cancerous tumor, then we may want to intervene.
And regarding a biopsy, Dr. Shapiro, how safe is it to biopsy a possible kidney tumor?
Yeah, biopsy is a very safe procedure. So at the University of Wisconsin, we do quite a few biopsies in patients, and we've written pretty extensively about it. In our large series of biopsy patients, we found that complication rate was less than 1%. And so the typical complications that can happen from a biopsy, the most common one is bleeding from where the needle enters the tumor. But that's very rare where it would be a significant enough bleeding where we would need to do any sort of intervention or give a blood transfusion. So overall, it's a very safe procedure. Another thing that patients often ask about when considering a biopsy is the tumor going to spread because we've poked the tumor with a needle? And we know that that's extremely rare. We quote a number of like 1 in 10,000, but it's probably so rare we can't actually quantify it. So in terms of the likelihood of it spreading cancer is very, very low, basically case reports of that.
And one last question for you, Dr. Shapiro. Because a CT scan was already done, is there any additional imaging that will be needed at this time?
So typically when we're doing evaluation of kidney tumors, if we are concerned about cancer, we'll often do what's called staging evaluation. And basically what we're doing there is not only looking at the kidney, but looking at other areas of the body that may potentially harbor cancer that is spread from the kidney. And so one of the most frequent places that kidney cancer might spread to is the lung. And so oftentimes we will get additional imaging of the lungs, either a chest X-ray or a chest CT scan, just to confirm that the tumor hasn't spread. But in this patient's case, while I would still recommend getting staging imaging, I would discuss with the patient that I think the likelihood of this tumor having spread, given its small size, is very low.
Thank you. James had a biopsy of the mass, which showed that it was papillary renal cell carcinoma. Dr. Kapoor, can you talk about the pathology of the papillary renal cell carcinoma and how you can tell if it's papillary renal cell carcinoma compared to another kidney cancer type?
Yeah, thank you. Yeah, so papillary renal cell carcinoma is a subtype of kidney cancer. It is the second most common type. It's generally considered to have a more favorable behavior than other common RCC subtypes. So here, what you're looking at on the left is the image of a normal kidney, and you're seeing a glomerulus in the center, which filters the blood and makes urine, and it's surrounded by these normal tubules. Papillary RCC is believed to arise from the cells lining these tubules and has acquired certain genetic changes like changes in a gene called MET and also gain of certain chromosomes like 717. Yeah.
Thank you. James wants to treat the mass and requested a treatment option that would allow him to recover quickly as he still works full time. There are several possible treatment options for small tumor like James has. The slide shows the treatment recommendations made by the National Comprehensive Cancer Network, or NCCN. These guidelines are used by doctors across the US and around the world to make treatment decisions for their patients. Possible treatment options for James could include a partial nephrectomy, ablation therapy, or radiation therapy. There are different types of ablation therapy that may work to treat James's tumor. Dr. Sheth, can you explain the different options and if there's a better option for James' situation?
Sure. So in interventional radiology, we use imaging to help guide needles or catheters through the skin right into the heart of tumors like James's tumor. And once the needle is in the skin, we have a variety of different ways of killing the tumor by delivering various forms of energy. So as you mentioned, we have radiofrequency ablation, which is where we burn the tumor cells to death. And we have cryoablation, which is where we freeze the tumor cells to death. And so we could deliver either side of the temperature spectrum to kill these tumor cells, either heat or cold. And from an efficacy standpoint, we believe both of them to be effective. So typically, we're not choosing one over the other based on the sentiment that one might be more effective than the other per se. We typically choose one or the other based on other sort of anatomic considerations. For example, what location in the kidney the tumor might be, what the nearby structures might be, because of course we want to destroy the tumor cells, but equally importantly, we don't want to destroy the normal tissue that's nearby it with the energy that we're delivering. So typically we're choosing the type of energy based on these other sort of secondary considerations rather than which one we believe to be more effective, because we believe both of them to be effective, and from a procedure standpoint, from the patient's experience standpoint, they're quite similar. It's about an hour long in terms of the procedure itself. It's usually an outpatient procedure, and they go home either that day or the following day. So from the experience, it's not terribly different. In James's case, with the size here, we would probably choose cryoablation to treat the tumor, and that's again based on sort of secondary aspects of it. But the expectation would be that we should be able to get good outcome for this patient and sort of achieve his goals of being able to get back to his daily life quickly.
Thank you. Now, radiation therapy is also an option that James could consider. Dr. Hanan, can you talk more about the role of radiation for a small renal tumor?
Absolutely. So the type of radiation we use is called stereotactic radiation, abbreviated SBRT, or you may also hear about SABR. The acronym stands for stereotactic ablative radiation. The key is that it is advanced enough technology that allows us to focus radiation to a tumor that can be located anywhere in the body, in this particular case, in the kidney. And it's given in one setting or three settings typically. We have reported studies and data showing that the local control or the cure rates can be as much as 95 to 100%, with the side effect rates that are on the order of typically around 3 to 5%. Primarily, transient nausea can happen in some patients, and transient tiredness and fatigue can happen in some patients. So to briefly walk through of what James would go through is first, after initial consultation, he will come in for a radiation planning session. We sometimes call it simulation. That's when we'll make a mold or a cast for his body to fit him snugly. And then we will do some measurements. We may give IV contrast. We will do a CT scan or an MRI, and we will monitor how the tumor is moving with the kidney. And then a lot of planning goes in the background for about a week. We optimize the radiation plan. We do a dry run, do quality assurances. And then when the plan is absolutely ready, James would come back on the day of the radiation. We will put him back onto the same mold that we made for him. And then he'll lay on a table with a machine going around him. It's an open machine typically that gives the radiation from all around, focusing it right onto the tumor. Typically it takes about 30 minutes or so. Then for the most part, tumors we are able to treat in one setting, but some tumors we may need to do it in three settings. Typically, my patients are coming in their lunch break, so James actually doesn't have to even miss a day of work. And then some side effects can happen. One of the late side effects we have seen is a slight decline in the kidney function of the same kidney that we're treating, typically on the order of 5 to 10%.
Thank you so much. James' care team agreed that radiation or ablation would allow for the fastest recovery compared to a partial nephrectomy. James decided that radiofrequency ablation would be the best option for his situation. Following the ablation, James had a CT scans regularly to monitor the initial tumor and to ensure that no other masses grew. 3 years after his ablation, another small mass was discovered on James's left kidney, close to his original tumor, during a follow-up CT scan. His urologist recommended a partial nephrectomy this time to treat the reoccurrence. Dr. Shapiro, can you give us more information about a partial nephrectomy and what the different types of surgical approaches are and which option would be best for James?
Sure. So a partial nephrectomy is where we essentially just try and remove the tumor from the kidney while sparing as much normal kidney tissue as possible. And the goal there is to try and maintain a patient's renal function as best we can, so that they don't lose renal function over time as they get older. So in terms of how we approach the kidney, there's different ways you can do a partial nephrectomy. So one way is to do an open partial nephrectomy, and typically that's done through an incision through the flank, basically next to the ribs, and then we dissect down and cut it out without, it's basically the old-fashioned way. But reasons that we might do an open approach is it gives us the most visibility. Also, sometimes we can put ice on the kidney, which also helps to reduce how much damage there is to the kidney. So when we cut into the kidney, we have to clamp the artery going to the kidney so that the patient doesn't lose a lot of blood. And so we try and minimize how long that the artery is clamped, because if the artery is clamped for a long time, there can be permanent damage to the kidney. And so if we're dealing with like a very large tumor where we expect it might be a longer period of time that the kidney is clamped, we may consider doing it open, which is a little bit faster. And then also we can put ice on the kidney, which may help to try and prevent some kidney damage while the kidney is clamped. But much more commonly, we do a minimally invasive approach, either laparoscopic, which is kind of not as common, but most commonly now we do a robotic approach. And the advantage of the robotic approach is we don't have to make a big incision, so there's less recovery time. The incisions we make are about 1 centimeter in size, and we usually put 4 ports to use for our robotic instruments. And then we use our robotic instruments to essentially perform the same operation where we cut the tumor out and then sew the kidney back up. And so for James's case, I think a robotic approach would be reasonable. Some complicating factors in James's case is he had a previous ablation, which can make the partial nephrectomy dissection a little bit more complex just because we know there's going to be some scar tissue from his previous ablation. But it's still technically possible. And the big thing with the partial nephrectomy is just making sure that we get all of the tumor out. And so we're very careful about making sure that our margins are negative and not leaving any tumor behind. And then in terms of complications from partial nephrectomy, blood loss is the most common complication, but it's pretty rare that we need to give a patient a blood transfusion. Usually on the order of between 3 to 5% of the time we have to give a blood transfusion. And then another thing that we look out for, especially in a case like James where he's had previous intervention on his kidney, is sometimes we can get deep into the kidney where the urine collects, and sometimes that can leak out of the kidney. And so we do everything possible to make sure that we sew up any areas where urine might leak out of the kidney, but it's something that we always discuss with patients as a possibility anytime we're doing a partial nephrectomy. If that complication does happen, there's ways that we can fix it that are pretty straightforward and minimally invasive. And it's a pretty rare occurrence, but it's just something that we always counsel patients anytime we're doing surgery like this.
Thank you. James did proceed with a robotic partial nephrectomy, and the pathology showed that the new mass was another papillary renal cell carcinoma tumor. Dr. Kapoor, are you surprised that the second tumor is also a papillary renal cell carcinoma tumor?
Not really. So about 5% of patients can develop more than one kidney tumors, either in the same side, which is called ipsilateral, or in the opposite kidney, which is called contralateral. And this can occur either at the same time as the first diagnosis, which is called synchronous, or at a later time point, which is called metachronous. Sorry, I'm throwing a lot of words at you, but you may come across them in your reports. And so these are more often of the same histologic type, but rarely can be of different subtypes. In papillary RCC especially, it is not unusual to see more than one tumors. The risk of multiple tumors, often bilateral, is more common in patients who have hereditary syndromes such as VHL and hereditary papillary RCC. These generally tend to occur in younger patients, generally less than 45 years of age.
And can you talk more about the pathology information provided about this tumor, specifically the grade assigned to the tumor and how that might affect the final pathology?
Yeah, thank you. Yeah, so in the pathology report, we not only give the diagnosis, but we also give information regarding the prognostic factors such as grade. So when we talk about grade in cancer, we really mean how aggressive the tumor looks under the microscope. So in RCC, we use a grading system that mainly looks at the size and appearance of the nuclei, so those blue dots that you're seeing under the microscope of a cell. And these are the control centers of the cell. So bigger tumors, bigger nuclei are higher grade tumors, and grade goes from 0 to 1, from 1 to 4, sorry, and 1 being the lowest, 4 being the highest. The grade helps us predict how the tumor might behave, but it's just one of the overall variables that we provide. The final pathology report also provides information such as the tumor type, the size of the tumor, the stage, which is one of the biggest prognostic factors. And stage basically captures how far the tumor has extended, especially outside the kidney. And all these factors together help the doctor decide on the follow-up and treatment. So this tumor is low grade G2, where we can't see the nucleoli easily. So it's relatively more indolent.
Thank you, Dr. Kapoor. Dr. Shapiro, what follow-up care will James need to monitor for new masses in the future?
So after patients had treatment for their kidney tumor, we essentially sort of risk classify them and determine how likely it is that their tumor is going to come back. And then we sort of stratify based on the likelihood how frequently we'll image them to make sure that the tumor doesn't come back either in their kidney or elsewhere in their body. So we'll periodically get images, either CT or MRI of their abdomen, and then we'll also do periodic images of their chest as well, because like I said earlier, that's one of the common places that kidney cancer could spread to. So we'll monitor them for the cancer reoccurrence. We'll also carefully monitor his kidney function. So we'll check we'll do lab evaluations during every follow-up, and we'll look at things like the creatinine and the GFR, which are measures of how well his kidneys are working. And so those things combined will give us an overall picture of his kidney health and then the likelihood that his cancer has come back or potentially coming back.
Thank
I
you,
have a
everyone.
question.
Yep.
I have a question actually, perhaps for Dr. Kapoor. Since the tumor came back in the same kidney, is there a way by doing pathology to tell whether this is the same tumor that came back or it's another new tumor that grew? And perhaps what you do to try to find that out?
That's a great question. So if it is a recurrence, normally the margin is positive in the previous resection. Here it was a radioablation. So sometimes, but not always, we may see some reaction from the prior surgery. And if the tumor is around that area, it's very likely it could be recurrence, but we can never be 100% sure if it is of the same histologic type unless we do some kind of a molecular testing and show that the genetic makeup is similar to the prior one. Thanks.
One thing also for Dr. Sheth, in this patient, we didn't really say whether we thought this was a recurrence from the previous ablation zone or if this is somewhere else in the kidney. But if you saw a tumor coming back in the ablation zone, could potential repeat ablation be an option for this patient?
Yeah, thanks. So I think just like you said, if the imaging made it seem as though we're recurring right at the margin of the prior ablation zone, then definitely repeat ablation is an option. We can certainly do that to sort of clean up areas that might recur at the edge of ablation zone. So it's certainly something that we would consider as an alternative to a partial nephrectomy. I think probably in this case there was some distance between the ablation zone and the new tumor, which is where it made sense, I think, to proceed down the road for surgery.
I just wanted to add also, SBRT would also be an option in the setting of recurrence, and we did publish a small series showing that it could be effective in the setting of recurrence.
Thank you, everyone. That'll conclude our first case. We'll move on to our next case. This is about a patient, Ellen, a 52-year-old female who had been feeling more tired than usual and had dull flank pain on her right side. Her primary care physician ordered a CAT scan of her abdomen and pelvis to rule out any major issues. The CAT scan showed a 7.8 centimeter suspicious mass on her right kidney. Some nearby lymph nodes also appeared to be larger than normal. Her primary care provider referred her to a urologist for further evaluation. Dr. Shapiro, can you explain what the purpose of lymph nodes are and what it could mean if they're enlarged in the setting of a possible cancer?
Yeah, so lymph nodes are part of our immune system and basically help monitor for infection, and also they monitor for foreign proteins like could be produced by a tumor. But they also can be important in terms of cancer because it's one place that kidney cancer could potentially spread to. And so it's hard with kidney cancer to determine whether or not the cancer has actually invaded a lymph node if they're only mildly enlarged on a CT scan. So a lot of times kidney cancer creates a lot of inflammation. And so just the normal inflammation and reaction that your body has to the kidney tumor can actually cause those lymph nodes to become enlarged. And so it's sometimes helpful for us to biopsy a lymph node to determine if cancer has actually invaded that lymph node or not. Now, whether or not we need to do a lymph node biopsy depends on what our ultimate plans are for the patient. So if we discuss with the patient and decide to go for surgery, we may not necessarily need to do a biopsy before surgery because we'll be able to take out the tumor and then also the lymph nodes during surgery, and that will give us, more definitive information for someone like Dr. Kapoor to look at pathologically. So for this case, we wouldn't necessarily need a biopsy. However, if we, for other reasons, if we decided maybe giving systemic therapy first and not going straight to surgery, then we might opt to get a biopsy beforehand. As far as other imaging So as long as we've had good imaging of the abdomen, the other place that we might get imaging is the chest, like I talked about before, to complete our staging imaging. Now, if there is concern that the tumor has spread into other organs like lymph nodes in the chest or also invaded the lung, then we might get even further imaging like of the brain to see if the tumor has spread further. But usually we start with imaging of the chest and also of the abdomen. And then as far as treatment options for Ellen, so as far as for this tumor, because it's larger, partial nephrectomy, we may consider if for whatever reason her kidney function isn't very good. So if let's say she only had one kidney and we felt we could get all of the tumor out, then we might consider doing a partial nephrectomy. But if she had a normal healthy kidney and her kidney function overall looked pretty good, then most likely we would opt to do a radical nephrectomy, which is where we take out the entire kidney with the tumor. And then we would also, during surgery, remove all of the lymph nodes that we were concerned about.
Now, what would be a better option for Ellen, the radical or partial nephrectomy versus the radiation or ablation?
Uh, I guess I have to, do we have to have a cage match about it or? No, I think as far as what's would be the standard of care, it would typically be a radical nephrectomy. But yeah, I'll defer to radiation oncology and interventional radiology about what they think about those options.
Yeah, I can talk about ablation in terms of percutaneous ablation here. Wouldn't be a great option. The size of this tumor is almost 8 centimeters. When we do ablation for kidney tumors, our goal really is to try to get rid of every single tumor cell as a surgeon would if they did a radical nephrectomy. When a tumor is that large, it's very challenging to do that with ablation alone. There are some trials going on right now where people are looking into sort of newer techniques and combination approaches to try to expand the size threshold for ablation, but I would say I wouldn't put ablation, in the mix right now, certainly in terms of a first choice as an option.
And I can talk about the radiation and SBRT. So if patient is not a candidate for surgery, I think SBRT would be a great option, and I'll tell some pros and cons at the end. Typically, size is not an issue for controlling with the radiation, and we have controlled tumors as big as 10, 15 centimeters as well. We may just need to do 5 treatments instead of the 3 that I mentioned before. It's mainly the location and how the tumor is positioned. So if the tumor is entirely in the kidney and there's not much bowel, then size doesn't matter. But if the tumor is coming out or protruding out of the kidney and there is bowel right up against it, that makes it more difficult to control it with radiation. We are developing more advanced technology every day, and one of the newer one is the adaptive technology, which allows us to adapt based on even bowel movements, which can be unpredictable. So our reach of what we can control with radiation is changing daily. But this particular case, given that the lymph nodes are also involved, which also can be treated at the same time with radiation, but the disadvantage here would be that you would not know the pathology, or you would not know how aggressive the tumor is, or if you would not know whether the lymph nodes were really involved or they were just reactive. So, so if the goal is to control the tumor and kill the tumor adequately, radiation is an option, and absolutely an option when surgery is not possible.
Thank you, everyone. Ellen's doctor recommended that she undergo a radical nephrectomy with lymph node dissection. Dr. Shapiro, what considerations are needed during surgery when the tumor is spread to the lymph nodes?
Yeah, so typically during a radical nephrectomy, like I said, we'll take out the entire kidney with the tumor in it. When the lymph nodes are involved, we'll also plan on removing all of the areas of concern. What's interesting about kidney cancer compared to some other types of cancer like testicular cancer is the pattern of spread in the lymph nodes can be very unpredictable. So oftentimes if we're going to remove some lymph nodes, then we'll do what we call a template dissection, where we essentially remove all of the lymph node tissue in an area around the blood vessels in the belly to make sure that we remove not only the lymph nodes we were concerned about, but some of the other lymph nodes in the area that may microscopically contain some kidney cancer cells. As far as surgery goes, we'll take out the kidney with the tumor and then the surrounding lymph node tissue. And then as far as the approach that we'll take, it kind of depends on various factors. So you could do this open by basically making an incision down the middle of the belly, and that gives a lot of exposure, but the downside is it also takes a little bit of time to recover. The alternative option, which I think would be a reasonable option in this case, is to do a robotic approach where the incisions are much smaller, which makes the recovery a bit faster. And we would do that as long as we felt that we could get all of the cancer out and do a very thorough lymph node dissection and remove all the lymph nodes.
And what would the recovery look like after a radical nephrectomy with lymph node dissection?
Yeah, if we take the robotic approach, usually patients are in the hospital a couple days at most. The recovery is pretty quick, and we usually have patients up on their feet day one. And then I usually recommend to my patients no heavy lifting for about 6 weeks, so nothing more than 10 pounds. But patients usually are recovering pretty quickly and have not too much pain after the robotic surgery. If we decide to take an open approach, then the recovery can be a little bit slower just from the incisional pain. So patients might be in the hospital 3 or 4 days. But still, patients will be up, moving around day one after surgery. And I still recommend for those patients the same sort of precautions, no heavy lifting for about 6 weeks.
And what kind of considerations does Ellen need to take after surgery due to only having one kidney left? Would she need to see a nephrologist?
It depends on what her renal function looks like after surgery. So we typically recommend patients follow up with nephrology if their GFR, or their glomerular filtration rate, is less than 45. That's in our guideline recommendations. But I always, if there's any concern, I definitely get our nephrology team involved early on. And then as far as precautions you need to take, it's sort of general precautions that we would recommend to any patient regarding their kidney function. So eating a healthy diet, avoiding high salt in their diets, maintaining a healthy normal blood pressure, and then avoiding things that can damage the kidney long term, things like diabetes or obesity. Those are things that we try to avoid, especially in patients who only have one remaining kidney.
Thank you. The pathology from the tumor removed during surgery showed that it was a clear cell renal cell carcinoma. Dr. Kapoor, clear cell renal cell carcinoma is the most commonly diagnosed type of renal cell carcinoma. Do we know why that is?
Yes, so clear cell RCC accounts for roughly 70 to 75% of all kidney cancers. We think this is because the cells it develops from, so those cells around the glomeruli and the tubules, are more vulnerable to certain genetic changes, especially loss of a gene called VHL gene. So when VHL gene is not working, the tumor functions as if there is no oxygen and remains in a switched on state where certain growth pathways are activated, such as more blood vessels are made. And this leads to tumor development. These changes can happen by chance in a person's lifetime, and these are called sporadic, and this is the most common type, or rarely it can be in an inherited fashion. We don't really fully understand why clear cell RCC is so much more common than the other subtypes, but it's probably related to both the specific conditions in the kidney and how often the VHL pathway is disrupted in the kidney.
And Dr. Kapoor, during Ellen's surgery, there were several enlarged lymph nodes that were removed and cancer was present in them. How does this impact her overall diagnosis?
Yeah, so when kidney cancer spreads to the lymph nodes, it means that the tumor has already learned how to travel beyond the kidney. We use a staging system called TNM staging system to categorize the spread of tumor outside kidney or within the kidney. In staging terms, cancer in the lymph nodes is called node positive disease, or PN1. This moves the cancer into a more aggressive stage and generally means that there is a higher risk that this cancer cells may already have spread to other parts of the body. This information that we convey in the pathology report really helps the oncology team decide whether Ellen might benefit from additional treatment after surgery, such as immunotherapy, and also how closely she may need to be followed up afterwards.
Thank you. Because Ellen's cancer has spread to several lymph nodes, she has stage 3 cancer. The NCCN guidelines suggest that she may be eligible to receive additional treatment after surgery called adjuvant therapy. Dr. Plimick, would you recommend that Ellen receive adjuvant treatment?
So that's a great question. So Dr. Shapiro, after he completes the nephrectomy and she's healed, and Dr. Kapoor, after she issues the pathology report, this patient would likely end up in my office to discuss the option of adjuvant therapy. And it's a relatively nuanced discussion. So Ellen does qualify to be considered for adjuvant therapy because her tumor has learned, as Dr. Kapoor said, to spread to the lymph nodes and also is a grade 3, a high grade. Also, the margins are negative, which are required to qualify for adjuvant therapy according to the trials that were done. The way I think about whether or not a patient needs adjuvant therapy is based somewhat on their risk and also on their priority and preferences. So a patient like Ellen, we would be able to calculate her risk of recurrence of cancer. I say recurrence, but truthfully, Ellen is either cured completely by the surgery, meaning those lymph nodes were the last stop, they're all out of her, and there's no cancer in her body, or there's microscopic cancer that isn't apparent on CAT scan and wasn't apparent intraoperatively that's hiding in her body that may grow in the future into metastases or spread. And we can estimate the chances of this for Ellen, but we can't know for sure which category she falls in. So adjuvant therapy is treatment that we offer to increase Ellen's chance of cure from the surgery and decrease her chance of recurrence. That many adjuvant trials were done with all kinds of different treatments for kidney cancer. We do have one that ended up being a positive trial, meaning that patients in the trial who received adjuvant therapy had a benefit in aggregate over the patients who received placebo in the trial. But I think it's my responsibility to clarify the actual delta noted in these trials. And I think of this slide that I use in talks here, which shows the panel on the right is the placebo group. So those folks in red are these are 100 Ellens. Those are patients who will recur if they're not treated. And those patients in orange are patients who are already cured sitting in front of us, don't require further treatment. So if we then treat that whole cohort with adjuvant pembrolizumab, and you'll hear in a minute what that entails, we shift 8 out of 100 patients from the going to recur group to the not going to recur group. Another way of saying that is the absolute benefit of adjuvant therapy. It decreases a patient's risk of recurrence by 8%. And another slide, not this one, increases their chance of cure by 5%. And so those numbers to some people seem good and to some people seem small. The next part of our conversation is what you'll hear next from our clinical pharmacist, which is how long the therapy goes for and what the side effects are. And taken together, the patient's risk, the understanding of the potential of benefit, and then the administration, logistics, and side effects. Once the patient understands all those things, he or she is in a good position to make a decision through shared decision-making about whether adjuvant treatment is for them.
Thank you. You kind of segued it already, but the NCCN guidelines suggest that an immunotherapy medication called pembrolizumab, also known as Keytruda, can be used for adjuvant therapy for a patient that has clear cell renal cell carcinoma. How does that immunotherapy medication work to treat renal cell carcinoma?
So I can take that question, or Dr. Wayne can take that question. You can give me a nod.
You can take that question.
Okay, sure. So the way I explain this to patients is that immunotherapy and pembrolizumab is one version that we use. It's the one approved for adjuvant therapy. It helps teach the patient's immune system how to recognize and attack the cancer. When I go into more detail, it actually targets a protein that allows the cancer to hide from the immune system, thus allowing the patient's own innate immune system to be active, recognize the cancer, see it as an intruder, attack it, and potentially kill it very effectively, eliminating all the cells in the body that are cancerous through this process.
And then you or Dr. Wang can take the reins on the next question. How often is pembrolizumab given after surgery for stage 3 renal cell carcinoma, and how many treatments would Ellen need to receive?
Okay, so we give pembrolizumab here every 6 weeks, typically. It's in the study, it was given every 3 weeks at a different dose, but those have been shown to be equivalent. More competent they are. It is a lot easier for patients to come to the center and get infusions every 6 weeks instead of every 3. It's given for a total of 1 year.
Thank you so much. And we'll switch over to Dr. Wang. What are the possible side effects that Ellen may experience when receiving an immunotherapy medication like Keytruda?
Right, so at this point, Ellen and her family may be meeting us in clinic to go over to provide education regarding pembrolizumab treatment. And we would also kind of go over the number of treatments, but It's kind of tricky to answer this question. I always try to tell patients that these side effects are potentially rare, but definitely possible, that you may be experiencing this since we are revving up your immune system. So it could cause an inflammatory response in practically, any organ in a wide range of potential side effects. But clinically, I definitely think we see a lot of endocrine type side effects. So, there's feelings of fatigue, weight fluctuations, cold intolerance, as well as dry skin, constipations, feeling thirsty, frequent urination, and increased hunger could be signs of those type of toxicities, such as hypothyroidism or developing a type of diabetes. Otherwise, maybe some other potential side effects that we see more commonly could be the coughing, shortness of breath, or chest pain to rule out inflammation in the lungs or pneumonitis. Things like diarrhea, abdominal pain, or tenderness to rule out inflammation in the GI tract or what we refer to as colitis. And then even just remembering to check your skin as well for the development of skin rashes, blistering, itching, those type of things to rule out inflammation of the skin. Perhaps they're slightly the more clinically common ones. But honestly, I think the take home is early awareness of these symptoms is very critical, whether it's a new symptom and or if you may already be experiencing some of these symptoms, if they do worsen while starting on pembrolizumab treatment, that it's just kind of time sensitive and critical just to let your providers know so that we can help better manage them.
I'll just add to that. That was a great summary. That we also like to emphasize that most people don't have any severe side effects from this. The subset that have sort of these severe autoimmune events, we estimate to be 10 to 20%. So it's okay if you have no side effects. It's a good thing, actually. And then because the list is so long of things that could happen, just like Dr. Wang said, we emphasize call us if something's not quite right. So even if it's not on the list of things that we say, close communication and early identification of these is critical.
I have a quick question for Dr. Plimak. Because I don't often get to have these discussions or be part of them, how often do you feel like what proportion of your patients after you're done discussing, the risks and benefits of pembrolizumab end up choosing to proceed with it? Do you feel like most patients after you discuss with them do want to go on and get adjuvant therapy, or do you feel like it's kind of a mix?
It's definitely a mix. I think people are really clear on their reasons for wanting it and not wanting it once they have a chance to understand it and think about it. I would say slightly more opt to choose it. But it's really such a balance, as you know, right, between side effects, time off of work or coming in, what some perceive to be a really small potential benefit from it. What's more endorsed, what people are more eager to accept is a clinical trial in the adjuvant space where we're really looking to give them the pembrolizumab, but give them something else to help it work better so that those numbers maybe in the future might be a little higher.
Thanks.
Thank you, everyone. That wraps up our second case. Our last case follows Alex, a 36-year-old male who was experiencing persistent back pain and fatigue for the last several months. His primary care physician ordered a CAT scan of his chest, abdomen, and pelvis showed a 9.3 centimeter mass on his right kidney. There were also several small nodules in his lungs that were suspicious for cancer. He was referred to a medical oncologist for further evaluation. Alex has a couple different areas where he could have cancer, and it's not known if the cancer is kidney cancer or another cancer. Dr. Sheth, is there a preferred spot to biopsy first?
Sure. So I think the preferred spot to biopsy is going to be the one that gives us the most information to help us guide with the subsequent decision making and treatment plan. So if there's some spots in the lungs as well as the large spot in the kidney, I think the most useful spot for us to do the biopsy from would be the lungs to see if that is an area where this kidney tumor might have spread. I think that'll help stage the patient the best and provide the most information for determining the treatment plan. As Dr. Shapiro mentioned, these biopsies, kidney biopsies and lung biopsies, should be considered very safe in general. He gave a risk of less than 1% for a major bleeding event. That's totally accurate. Likewise, with the lung biopsy, the risk of a major complication is around the same. So there's a different little profile of outcomes that can happen, but in general, they should be considered safe. And for this patient, I think a lung biopsy would provide the most information, and that would be, I think, the great guiding principle here.
Thank you. Alex had one of the lung mass biopsies, and it showed that it was translocation renal cell carcinoma. Dr. Kapoor, since the lung mass was biopsied, how would you know it's a renal cell carcinoma instead of a lung cancer or another cancer?
Yeah, so we look at the tumor cells under the microscope and compare them to the patterns we know from different tumors. So lung tumors look different from kidney tumors. When we suspect metastasis, we also often use special studies such as immunohistochemistry. These are assays that highlight certain proteins that are found only in one specific cancer type, but not in the other cancer type. For example, in this case, the tumor in the lung had the same microscopic feature that we see in a kidney cancer subtype called translocation RCC, and it's shown on the right side on the screen. And if we were to stain it, it would be positive for a marker called PAX8, which stains kidney tumors, and it would be negative for TTF1, which stains kidney lung tumors. So we know that this lung tumor is a metastasis from the kidney cancer and not a new primary lung cancer.
And what makes translocation renal cell carcinoma unique compared to the other subtypes of renal cell carcinoma?
Yeah, so translocation RCC is a relatively rare type of kidney cancer, and it tends to occur in younger people, including in children and young adults, but can occur in any age group. It results from a swap or translocation between parts of a chromosome that usually involve genes called TFE3 or TFEB. This change keeps these genes in an on state and drives the cancer growth. Under the microscope, they have a unique morphology. And as you can see here, the cells have a mixture of clear and pink cells. And that's not commonly seen in other cancer types. But I would say that this is one cancer type that can really mimic almost all other type of kidney cancers. And so we often use special stains such as FISH or molecular testing to confirm the diagnosis. And also that the reason for recognizing these RCC subtypes is that different subtypes have different prognosis and they behave in a different way. So knowing the exact subtype helps doctors choose the best treatment and also follow-up plan.
Thank you. Because the cancer has spread outside of the kidney to other parts of the body, Alex has metastatic kidney cancer. Alex's tumor was large and aggressive. His medical oncologist decided to begin systemic treatment with a combination of immunotherapy and targeted therapy. Cabozantinib, also known as Cabometyx, and nivolumab, also known as Opdivo therapy. Dr. Plimick, how does the immunotherapy drug and targeted therapy drug work together to treat renal cell carcinoma?
That's a great question. So I actually agree with this choice of therapy for this translocation renal cell patient. I also agree that starting with systemic therapy in a metastatic situation is the best place to start. We don't exactly know how the tyrosine kinase inhibitors, cabozantinib is one of them. It's a pill-based treatment that targets receptors targets the cancer itself. And nivolumab, which is similar to the pembrolizumab, which is talked about in the last case, helps the immune system recognize and attack the cancer. We don't know how these two work together, but we do know that each one, when combined, works better than either one alone. And so there are a variety of different immunotherapies with these TKI therapies that have been combined. And cabozantinib and nivolumab is an excellent choice for this patient. This has been studied in a large trial. It has also been looked at in non-clear cell kidney cancer, which technically translocation, gets Dr. Kapoor could comment, but technically translocation is considered in that basket. And so it's reasonable for this patient.
Thank you. Dr. Wang, what side effects could Alex experience because of the Cabometyx?
Some of the more common side effects we see with the cabozantinib would be an increase in blood pressure for sure, or hypertension. Worsening if you are already taking blood pressure lowering medications and may require increasing doses or adding additional agents to help better manage your blood pressure, or even new starts if you didn't have any issues with high blood pressure prior to starting therapy. So it's just important in general to start monitoring your blood pressure daily and recording it in a logbook while you're taking the cabozantinib. In terms of GI side effects, we definitely see a fair bit of diarrhea as well as decreased appetite. That's fairly common, as well as fatigue, changes in thyroid function, particularly hypothyroidism that would require thyroid supplementation, as well as hand-foot syndrome can occur. So you could potentially develop like redness or swelling or pain and sometimes blistering to your palms of your hands or soles to your feet. So upfront hydration and utilization of unscented moisturizers like urea cream or things like CeraVe are important to try to help prevent that. In general, it's just also important to note that if you are going to have any upcoming procedures as well, the drug class as a whole, cabo being one of them, can impact wound healing. So just one of those things that you want to just let your providers know, because depending on the procedure, we may need to hold it prior to and after to allow for a better wound healing.
And Dr. Wang, can the side effects be worse because Alex is also taking the nivolumab?
Yeah, so very interesting. I think it's tricky to say that the side effects would be not, I don't think of it as necessarily being worse per se, but it's just that both the cabozantinib and the nivolumab do have a lot of potentially overlapping side effects. So if you kind of picture a Venn diagram, if you will, there's just kind of a lot that incorporate both that could happen with either the cabo or the nivo. So I think from a side effect perspective, like I just mentioned with the single agent cabozantinib, so, things like the diarrhea, endocrine changes, skin changes, that could be due to either the cabo and or could be from the nivolumab. And so in some cases, the management of the toxicity may be the same. So perhaps it's not as important to figure out which is driving it. Is it the cabo or is it the nivo? So things like your endocrine, for example, changes to your thyroid functions. If we need to start a thyroid supplement, perhaps it is not as critical to figure out which one is driving it. But in the example of the diarrhea, we would want to have a better feel and ascertain if it's the cabo driving it or the nivo, just because the management could be a bit different. And the workup would certainly be a little bit more extensive to try to figure out the cause.
Thank you, Dr. Wang. Dr. Hanan, could radiation be used to treat the metastatic cancer in Alex's lungs?
That's a great question. So I'm going to break down that question into two parts. So one part is, can lung metastasis be treated safely and effectively? And the second question is, will that benefit the patient? So the first answer is easy. We are treating lung metastasis safely and effectively all the time. Again, local control or local cure rates could be as high as 98 to 100%. So that's not the issue. Now, the second question is a little bit difficult to answer, is whether this will benefit the patient or not. So to answer that question, I'm going to use an analogy. Let's say you're gardening and your garden is getting weeds, right? So now it's getting a lot of weeds. You can go and manually take out a weed and that will be successful, but will that help you? Because another weed is going to just come up in another place. But let's say now you're using weed killer and you're using it, it's working very well year after year. But after using it for some years, some weeds start to come up because they became resistant to that weed killer. Now, in that setting, it may make sense to bring in radiation or manually go in and take out that weed that became resistant, or you could change the weed killer completely, bring in a more toxic or more potent weed killer. So that's kind of what is going on here. So this is the setting what we're calling oligoprogression. So if you have 1 or 2 or 3 tumor sites that become resistant to the drug, given that the drug is working, so everything else is controlled, but 1 or 2 is becoming resistant, that would be a very good and strategic way to bring in radiation therapy to maximize or harness the maximum benefit of the ongoing systemic or drug therapy, given in particularly in this case where there isn't too many drug therapies that are known to work for these rare types of kidney cancer. So it makes the most sense to bring in radiation and harness the maximum benefit. So this would be a situation where radiation could be beneficial for Alex.
Thank you. I like the analogy. Since it was approved for use 10 years ago, Opdivo has been administered via IV. But in the late 2024, Opdivo was approved to be given by a new method, subcutaneous injection. A subcutaneous injection is a shot given just under the skin into the layer of soft fat and tissue between your skin and muscle. Subcutaneous Opdivo can be administered in the abdomen or in the front of the thigh. Dr. Wang, are there benefits to receiving sub-Q Opdivo versus IV Opdivo?
I think perhaps one of the biggest benefits to patients is the feasibility of being able to receive a sub-Q injection, which is just in general a lot faster. So the nivolumab sub-Q is going to be injected over 3 to 5 minutes, versus getting hooked up to an IV, which would be infused over 30 minutes. So that could just kind of potentially help shave off some time, especially if you've been in the hospital all day, you know, getting your labs, if you needed to get any sort of imaging, and then with your appointments with your providers. But I will say maybe just the caveat is that it's still pretty new. So some hospitals may still be adding it to their formulary. So that could be a potential barrier to receiving it.
And Dr. Wang, are there side effects for the sub-Q Opdivo that don't occur with the IV option?
Right. So given the vehicle of administration, there are going to be more injection site reactions with the subcutaneous nivolumab. In the initial study, I think there was maybe about 8% reported infusion-related reactions. Other than that, though, I will say the side effect profiles did seem to be very similar between the subcutaneous and IV versions.
Thank you. For clinical trials, they may be a good option for Alex if his current treatment isn't effective. Dr. Plemick, why are clinical trials important?
I love this question. Thank you. So all of the treatments that you've heard about today came to be through clinical trials, in particular the systemic therapies, which the medical oncologists like myself give. So, the cabozantinib nivolumab that was recommended for Alex, that's recommended because we know in a clinical trial it worked for his translocation renal cell carcinoma. And those people who participated in that clinical trial benefited Alex, but also achieved benefit because the combination was actually better than things we had before. So clinical trials are important to the patient in front of us. We try to make sure to offer them and offer good ones because it gives them access to something potentially better than the standard of care, but it also just moves the whole field forward and benefits everyone down the road. So that's why they're important. There are lots of different versions of clinical trials. People think a trial is only when you've run out of standard options. Sometimes that's true, but not always. People think there's always a placebo arm. Very rarely now, certainly in kidney cancer, would there ever be a trial with a placebo arm. But it is important to go to a center that has trials that offers them and that can explain to each patient both a standard of care option and a potential clinical trial option.
Now, in Alex's case, would it be used only as a last resort treatment option?
I would say no. There are a lot of novel therapies in kidney cancer that are bubbling up and in development. We're really excited about a number of them. He's starting on a standard treatment as his frontline treatment, which right now is probably the case for most patients with renal cell carcinoma. But in his case, his next line treatment, if there was something specific, a really good trial, you could certainly consider that, knowing that there are other standard options after that to try. So rarely now are clinical trials truly a last resort for patients. Typically, our patients are offered them at most of the stages in their care. Going back to the prior patient, Ellen, she could have been offered a clinical trial in that adjuvant setting as well of pembrolizumab plus a treatment to help it work better, for instance. And some patients really, really like that and prefer to enroll in something that might has the standard embedded in it, but might have something added extra for extra benefit.
And how would Alex's doctor determine if a clinical trial was a right fit for him?
So hopefully Alex's doctor has clinical trials at his or her sites, right? And would have options available that they've selected, right? We select very carefully the trials we have at our site to pick drugs that we're interested in, trials that we call equipoise, so we feel good about, sort of offering to our patients. And we don't open trials that don't fit those criteria for us. So ideally, Alex's doctor would be in the same boat and have options there. And also, those of us who are in renal cell carcinoma, a lot of us know each other and know what trials are available at other sites. I've referred patients to other sites for very good trials they have there. We've had patients come to Fox Chase from Virginia to China for clinical trials that we have here. So having a doctor who either has trials at their site and or knows what trials are available elsewhere, I think is critical. Typically, that's at an NCI designated cancer center, but not always. There are a lot of really good community practices that are either up to date on what trials are available or are able to call one of us to ask what trials are available for a given patient.
Thank you. That concludes our final case for today. A big thank you to everyone. Personally, thank you very much for working with me today. It was a pleasure working with all of you. Thank you to Dr. Hanan, Dr. Kapoor, Dr. Plemick, Dr. Shapiro, Dr. Sheth, and Dr. Wang. We hope that you guys found this session interactive and informative and have a better understanding of how doctors and clinical teams make decisions with real-life kidney cancer cases.